differences of where people are have less to do with cannabis itself and more to do with the person. And so understanding cannabis is important, but it's not sufficient, right, for being able to determine where somebody is on the spectrum. That's where we really need to use our clinical tools and assess their unique vulnerabilities, their unique strengths, and what the exposure to cannabis means to them. So the way I'm going to structure our time is really in 2 sessions with a break in the middle. The first part of the talk, I'm going to be imparting more information, talk about some policy background, how did we get where we are today with respect to cannabis, and then address several common myths that that you commonly hear around cannabis. That it's just an herb. What could be such a big deal about something that's an herb? The cannabis has no legitimate medical benefits at all. This continues to be the position of our federal government on cannabis. Conversely, the cannabis is totally harmless, right? It's an herb, it's natural, there's no harm to cannabis. And then finally, the cannabis is not really addictive. And all of these are common myths that we're all exposed to, and they all have seeds of truth in them, and they also have problems intrinsic to them. And then we'll talk about some implications of that. The second part of the talk, I'd like to organize around a case and talk about the clinical challenges that we encounter around trying to assess and treat somebody that has a cannabis use disorder. And we can also go, I think, in the second session, because I think I'm going to tire you out and myself out just talking at you for 2 hours. That second session we can make more interactive, and I brought my case, but we can use yours. And so if you have specific clinical challenges, quandaries, questions, we can kind of really try to integrate that into the second component. So in terms of my own disclosures related to this talk, none of my financial interests have direct bearing on what I'll be presenting to you today, but there they are, federal grant, and a board member of a clinical trials company and an advisor to a company that provides digital health services for addiction. With respect to off-label medications, there are no FDA-approved medications for the treatment of cannabis use disorder. When we get to the second part of the talk, the assessment and treatment, I will talk about some medications. They're all off-label. And as I will convey to you, the evidence for all of them, unfortunately, is quite poor. The evidence for psychosocial intervention is quite strong. So, okay. So with that, a minute history on how we got where we are today. Characterizations of cannabis go way back. In 2700 BC, the Emperor Sheng Nung, in composing or leading to the generation of a pharmacopoeia in China, characterized cannabis as useful for constipation, malaria, rheumatic pains, a variety of indications. And so we have documentation of cannabis's use for therapeutic applications dating way, way, way back. In the 1850s, cannabis was characterized within the U.S. pharmacopoeia as a quote-unquote legitimate medical compound, again, used for a variety of indications for tetanus, typhus, cholera, rabies, addiction, and so forth. It wasn't until the 1930s, till 1937, that cannabis was first regulated in the United States. Whoa. That had a life of its own. That was with the Marijuana Tax Act. And the Marijuana Tax Act was the first federal restriction on the use of cannabis. It placed a $1 tax on cannabis. And then in 1970, and this is what really kind of presages the slide that's to come, Richard Nixon established the Controlled Substances Act. And the Controlled Substances Act established the DEA. It established the scheduling system, which scheduled controlled substances. And the Controlled Substances Act was also part of a broader initiative, which Nixon really drove at, which was described as the war on drugs. And we'll talk about that in a moment. But one of the things that happened with the formation of the of the DEA and the scheduling system is that Nixon commissioned panels of experts to make recommendations on where drugs should be scheduled. Should they be Schedule 1, which is a highly restrictive, no medical benefits schedule, or a lower schedule? And these experts came back with guidances on various drugs, and on cannabis they said, well, there's not great evidence. There's some evidence of therapeutic, application. There's some, evidence of some risks. It should be on, Schedule 2 or Schedule 3. It should not be Schedule 1. And this was Nixon's response. He said, it's a funny thing. Every one of those bastards that are out there for legalizing marijuana is Jewish. I suppose it's because most of them are psychiatrists. There's so many. All the greatest psychiatrists are Jewish. And I love this because this is one of those statements that you don't know whether to be offended or complimented by. And it also, puts other things in perspective. Unfortunately, Nixon's war on drugs was quite successful. And what you see is that from the 1920s through the 1960s, really up until 1970, this is a characterization of the numbers of people that were incarcerated in the United States, right, from 1920 through 2007. And you can see that there was a there was a growing number. We have, growth of the population year over year. But you see that something changed profoundly in the 1970s, right? And that growth, from 1980s, onwards, the number of arrests for all crimes increased by about 28%, and the number of arrests for drug offenses rose 126%. So a lot of the growth of incarceration of Americans was due to incarceration of people for nonviolent drug offenses. And cannabis charges were the fourth most common cause of arrest. And they exceeded the total combined arrests for all violent crimes. What's more is there was very well documented disparities in cannabis arrests, right? So in New York, between 1997 and 2006, there was a study done. And if you were black, 27% of the population was black, but black people represented 54% of cannabis arrests. And white people were 36% of the population, but only represented 14% of cannabis arrests. So there were many disparities in how the criminal justice interventions for cannabis and for other substances were meted out. And there was also, on the public health side, very little indication that this correctional system was actually correcting the problem that it was intervening on. In fact, the problem was just getting worse and worse. So, really widespread concern around this helped to change popular opinion, was one of many factors that changed attitudes around cannabis. And the Pew Research Center for years, dating back to the 1960s, has been asking people about their attitudes, beliefs, and practices related to cannabis. And in this poll, they've asked consistently, do you think that marijuana should be made legal or not? And you can see that, that those numbers have flipped, that the percentage of people that have indicated that cannabis should be illegal or legal, in around 2006, which 2006, by the way, is when California passed the Compassionate Use Act, have switched. And if you dig into their survey, you see that fewer and fewer people see cannabis. By the way, I use cannabis and marijuana interchangeably. They're synonyms. But fewer people see marijuana as a moral issue, and fewer people see criminal justice interventions as effective or worth the cost. And if you break out this data by demographics, so age groups, you see that the most profound growth is in the youngest populations, but essentially every demographic group that has been surveyed has increased with respect to their perceptions around cannabis legalization. So there are few policy questions for which there's this much consensus, within our country, I would suggest. And this popular attitude around cannabis has helped to drive significant changes in policy. And this is a policy map of the United States, specifically around cannabis policy, marijuana policy. And what it shows is essentially the more green the state is, the laxer their policy is around cannabis. So the gray is total prohibition for any use. And then you get kind of this light green if there's legalization for medical use, some therapeutic applications in a restrictive way. Then there's a darker green for kind of broader legalization for medical use. And then the dark green is for full legalization. There's actually a lot more kind of finer colors to all of this, but what this demonstrates is the kind of progressive greenification, of the country around cannabis. And there really should be a different color for the total legal recreational use, because that's quite a different phenomenon than use for therapeutic purposes. So 2 remarks, about this. So, the popular attitudes have been a significant driver to change this, but so too has the attractiveness to policymakers of revenues associated with the cannabis industry, right? That's been a huge factor in this change and continues to. It's one of the reasons we're unlikely to see this turn backwards. In November of 2016, California voters approved Proposition 64, which is also known as the Adult Use of Marijuana Act, AUMA, by a pretty sizable margin. And this established legal marijuana in California. And as of January of 2018, legal sales, commercial legal sales were established. So what does this law say? It says that if you're an adult, which is defined as 21 and over, below 21, adolescent, this law doesn't apply to you. It's still illegal to use cannabis. You're allowed to possess, transport, obtain, give away small amounts of cannabis. Well, not small, less than an ounce. That's not exactly small. To cultivate a certain quantity of cannabis. That their agricultural production of industrial hemp is permitted, and retail sales, is permitted. And a tax has been established. There's some details in there we can talk about if you have any questions. But this is remarkable in that it establishes a commercial industry around cannabis use. This is not just removing penalties. Cannabis was already decriminalized in California, but this is laying the foundation for a commercial industry around cannabis use. What's prohibited? Marketing, advertising, providing to minors. Smoking in public spaces is punishable by a large fine of $100. I'm sure nobody here has smelled or noticed anybody smoking in public spaces, especially around here. A DUI is there are some other fees associated with this stuff, but the base fine for a DUI is $250. We're still having trouble characterizing how you establish a DUI for cannabis. And possessing, greater than an ounce, more than the allowable plants in your home, selling illegal distribution. These are misdemeanors by and large. And this is a picture of a dispensary called, well, I guess the name is not important. It's one of the big kind of venture-backed dispensaries that is promulgating, selling recreational cannabis use. And they have a storefront that is right outside of Cedars-Sinai on Robertson. It's on Robertson, right where all the for you guys that know Robertson, there are these furniture stores and boutique retail stores where you can get a T-shirt for $300 or more on sale. And then there's this store, and I had to check it out. It's beautiful. I mean, it looks like an Apple store. It's the design is beautiful. There are these displays, and this is another version of the store. Over here, these are iPads that are interactive with detailed information. You don't see it in this picture, but there's tons of, kind of like an Apple store. There are the geniuses. There are bud tenders, and they're there to helpfully shepherd you through all of their product and give you personalized information. And the branding and the marketing around this is incredibly powerful. It is remarkable, and this is, in my view, a pretty massive social experiment. It was a question?
Yes. So the law pertains to actual leaf and buds, but what about like honey oil and the other derivatives?
What about the honey oil and the other derivatives? Yeah, the law does have some guidance around that, but it's pretty permissive. And as you can see, I mean, if a lot of what these stores are selling are many other distillations and products that carry THC and other cannabinoids. We'll talk about that, in a moment. But you're right; it's one of the significant issues and limitations of the evidence that I'll present to you is most of it is backwards looking. It's focused on people who smoked cannabis buds, cannabis leaves, and increasingly we see people are vaporizing a wide range of other cannabis substances besides the buds and leaves. Okay, so what happens to consumption of cannabis when you increase the availability of a substance, you decrease its price, you decrease perception of risk around the substance, you commoditize it by creating an industry. This thing is just firing on its own. I'm gonna not even touch it. And you create special interests around it. Well, it's been very well characterized. You're expected to see an increased consumption. And if you look at, my hands are not even touching, this is incredible. Somebody have a thing in there, and they're trying to keep me going. Mo, is that you? Yeah. If you look at epidemiologic data on cannabis consumption, some people point to it and they say, hey, there's no increase in consumption. It's about the same percentage of the population that's using now that was using before on a percentage basis. And that may be true, but the percentage of over 50% of the population had tried cannabis kind of prior to all of this. So the prevalence of exposure to cannabis, lifetime use, was already quite high. Lifetime use may not be changing that much, but what we see changes is in intensity of use. And that is measured much less frequently. So people that might have smoked once in a while, once a year, or once a month, are much more likely to smoke once a month, or the once a month smokers once a week, or the once a week, once a day, or multiple times a day, or quantities of THC exposure that were just not possible when people were smoking buds and loose leaf. And there are some indications, if you look at intensity of use, so this looks at past year users, past month users, past month use days, and daily users, that you see a profound increase in growth. This is the percent change since 2002. So these kind of up-facing curves represent a real significant intensification of the intensity of use. And we're seeing that across the population, particularly in older smokers. We're also seeing, this is now outdated because this ends in 2012, and this data, the top graph is based on potency of cannabis, concentration of THC from drug seizures, which now you can just actually go to a facility and they test it themselves and they'll tell you what the potency is. And so this showed the progressive increase in the potency of cannabis buds up until 14% in 2012. Now if you look at the oils and the waxes, I'm gonna have to keep me on point. If the oils and the waxes, can get well over 80 to 90% concentration of THC. And in parallel to this, we've seen an increase in drug-related emergency department visits for cannabis-related presentations, while other substance presentations have remained relatively static, perhaps with the exception of, well, not perhaps, but it's clearly with the exception of opioid use disorders. The heroin data here ends in 2011, so you're beginning to see the upswing on that side. So, okay. So myth number one, isn't cannabis just an herb, right? It is an herb, isn't it? Well, it is, and so is oregano and thyme and rosemary and marjoram, all these. But cannabis is a very unique type of herb, and the problem with the myth that cannabis is just an herb is the notion that it conveys and that it equates is that cannabis is just like any of those other herbs that we might use for cooking. So the proper name for cannabis or marijuana is Cannabis sativa. There are several subspecies of cannabis, including Cannabis indica, and now there's a lot of hybridization and many, many different cannabis-related species. Traditionally, cannabis was was available in the form of kind of loose leaf marijuana, the cannabis buds without the seeds, sensimilla, hashish, which is the pressed resin from the cannabis leaves that was a little bit higher in THC, and hash oil. And you can see all these formulations that existed, and people would smoke it, vaporize it, inhale it, mostly bring it into their bodies through their lungs. So what was it in cannabis that was reinforcing to people? So there are over 400 hydrocarbons in smoked cannabis, different substances in cannabis. A lot of them are the same substances, hydrocarbons, that you see in tobacco smoke. But what is unique to the cannabis plant is these substances called cannabinoids. And there are, depending on what you read, 30 to 80, some say more, cannabinoids. These are chemicals that are unique to the cannabis plant. And among them, this cannabinoid that was discovered in 1965 in the lab of an Israeli researcher called tetrahydrocannabinol, THC. And THC was discovered to have the predominant kind of psychoactive effects of cannabis. If you extracted THC from the cannabis plant, it didn't get people as high. If you gave people pure THC, it would get them high. It would have the clinical effect that we associated with cannabis. So the discovery of THC generated a lot of interest about what exactly is this really specific compound in this plant doing in the brain or in the body. And that ultimately led to the discovery of several receptors that bind this compound. They were described as CB1, the cannabinoid 1 receptor in the brain that is stimulated by cannabis, and CB2, the cannabinoid 2 receptor. These were discovered in the 1990s, and what's interesting is that the cannabinoid 1 receptor, which is localized mostly in the brain, is one of the most prevalent receptor systems in the brain. It's also found in some other areas of the body, but the cannabinoid 2 receptor, which exists a little bit in the brain, is found in more areas of the body. The cannabinoid 2 receptor is expressed on immune cells, on peripheral nerve terminals, and microglial cells, a wide range of other activities. So the discovery of these receptors, the cannabinoid 1 and the cannabinoid 2 receptors, in turn stimulated another question, which is, what are these receptors doing in the brain and in the body? Clearly, they're not sitting around waiting for somebody to smoke a plant and be stimulated by a compound within that plant. And so this set forth a search for what the endogenous ligand is, the natural stimulus for these receptors in the body. And that was ultimately discovered to be a compound described as anandamide. And anandamide is synthesized from arachidonic acid. It's a fatty acid. It's one of at least 2 endogenous neurotransmitters that stimulates the cannabinoid receptors. And to the body's cannabinoid receptors, it looks, THC looks a lot like anandamide. So THC essentially mimics the effects of these endogenous cannabinoids. And so what's been interesting about this, and we're at the cusp of learning about this, it was just in the 1990s that the receptors were discovered for this, and shortly after that the endogenous ligand for this was discovered, is that the receptors, the natural neurotransmitters that stimulate the receptors, are part of what is now characterized as the endogenous cannabinoid system, the endocannabinoid system. It's a really broadly distributed system in our brain and in our bodies, and anything that is that broadly distributed must be important, right? It's there for a reason, and we're trying to figure out exactly what that system does and how it's influenced by cannabis. So what do we know about it thus far? Well, what the system appears to do is the following. So this is I'm scared to touch the laser pointer because it just fires off, but that's a presynaptic neuron. And ordinarily the way neurons communicate with each other, look at that. I wish I could do that outside of when I'm presenting, just, So the presynaptic neuron communicates with the postsynaptic neuron by releasing a neurotransmitter, right? And here you have, in the typical fashion, this could be serotonin or dopamine or GABA. This is a neurotransmitter that's released by the presynaptic neuron to stimulate the postsynaptic neuron, usually kind of a one-directional system. The endocannabinoid system is what's called a retrograde presynaptic signaling system. You're coming to fix the...
I'll pull it out so it stops doing that.
Oh, it's this?
Yeah.
Oh, okay, can I just pull that out?
Yeah.
I won't have an excuse for all my fumbles anymore. There you go. All right. Okay. All right. So, so this is the neurotransmitter with signal transduction from the presynaptic neuron to the postsynaptic neuron. What you see here is anandamide, AEA, or 2-AG, which is a different kind of anandamide. And it's this little green triangle here. And what you could see is this is a retrograde presynaptic receptor modulator, which means it's released from the postsynaptic neuron, and it travels backwards and stimulates a cannabinoid receptor, which is on the presynaptic neuron. And what that does is it sends kind of a feedback inhibition regarding release of the neurotransmitter that is getting that is communicating between the pre and the postsynaptic neuron. Okay, so why is this important? This level of detail, and this is about as detailed as the science will get, or as the neuroscience will get in this talk. So thank you for bearing with it. The endocannabinoid system is a modulatory system. It modulates the release of other neurotransmitter systems. It appears to kind of modulate the gain on that system. So it's not like, if this is the volume, right? This is the gain. And part of the subtlety of cannabis's effects probably has to do with that fact that it's modulating other neurotransmitter systems, as opposed to you give somebody methamphetamine and it causes a massive release of neurotransmitters directly, plus it directly stimulates these receptors. You get a very, very different, profound effect. The effect of cannabis is subtler, but highly widespread. If you look at where cannabis is, where cannabinoid receptors are distributed throughout the brain, now this is the brain of a rat, and it's been stained for cannabinoid receptors. So the dark you see represents kind of the density of cannabinoid receptors in the brain. You could see that cannabinoid receptors are broadly distributed throughout the brain. Their highest density is in areas like the basal ganglia, the cerebellum, which is involved in motor coordination, the hippocampus, this little seahorse-shaped thing over here, which is involved in memory process. Incredible. The cerebellum, you see a lot of it. Virtually the only area that you don't see any cannabinoid receptor stained is in the brainstem, right? And the brainstem is the part of the brain that controls vital functions, like breathing, right? Your heart rate. It's one of the reasons that cannabis alone, in and of itself, though it can cause a lot of things, it doesn't cause overdose. You don't have people dying from cannabis directly, because cannabis intoxication can affect many parts of the brain, but it doesn't affect the part of the brain that is responsible for vital functions, right? Like many other drugs that can be misused. So what does THC do? THC can alter mood. This can be a pleasurable alteration of mood. It can also be aversive alteration of mood. Gosh, it wasn't your thing at all. It was my computer. It can alter sensory perceptions, right? Sense of time, sense of novelty. The change in the sense of novelty, I think, is one of the most attractive things, particularly to kids, right? Because, a little cannabis, anything becomes interesting, right? You can watch a lot of really bad TV. The video game, it has endless, right? It's an antidote to the boredom that plagues us throughout various phases of life, especially teen years. It alters memory, alters level of arousal, attention, executive function, psychomotor activity. It also alters perception of pain, appetite, gastrointestinal activity, some of the stress reactivity and immune function, and also reproductive physiology. Now, these are just effects. Some of these, the experience of these effects, there's a lot of subjectivity to it. So some people experience the executive function impairments of cannabis as really aversive. I can't think, it's really frustrating. Some people experience those same effects and feel like it's disinhibiting. I can be creative when I use cannabis. Cannabis helps me do this, that, and the other. So some people experience the mood changes as pleasurable. Others feel that it makes them anxious. The way these effects are experienced vary from person to person a great deal. They're subject to context. They're subject to many other factors. And this is THC. And THC is just the beginning, right? Because there's a whole bunch of other endocannabinoids. This is from the laboratory of Raphael Mechoulam, the Israeli researcher that first discovered THC, and it's from one of his reviews characterizing all the other cannabinoids that are in the cannabis plant. So CBD, which is the cannabinoid in cannabis that is most described the therapeutic effects of cannabis, and for which there's a lot of interest, and then a lot of other cannabinoids, cannabivarin, cannabiglycerol, a lot of different cannabinoids that are in cannabis that we don't yet understand, that have varying levels of binding to the cannabinoid receptors, or that modulate other part of that system, inhibiting enzymes that degrade the body's natural endocannabinoid system. That's what CBD does, by the way. CBD doesn't actually directly affect the cannabinoid receptor. It blocks the enzyme, fatty acid amide hydrolase, that metabolizes our own endogenous cannabis. So THC is just the beginning. There's a lot more to the cannabis plant, and as the question in the audience represented, so too are cannabis flowers and leaves, many, many other formulations of cannabis that people are now using. Okay, so myth number 2, cannabis has, it has no legitimate medical benefits. I hope I persuaded you that cannabis is I've never had that happen, so I don't know what could possibly be driving this. I wonder if it's on some kind of timer. Anyways, hopefully you guys will bear with me. Cannabis has no legitimate medical benefits. This continues to be the position of our FDA and DEA, which recently reasserted that cannabis should stay in Schedule 1. And Schedule 1 means the drug or substance has a high potential for abuse, that the drug or substance has no currently accepted medical use in treatment in the United States, and that there's a lack of accepted safety standards for use of the drug under medical supervision. That's the definition. And if you ask patients, does cannabis have legitimate medical benefits, they answer very differently. So this is from a survey of 1,700 patients across a network of 9 California medical marijuana dispensaries. This is now data from 2011 that asked people at the dispensaries why they were using cannabis. Didn't ask their providers or their doctors. It asked them. So this is self-report. And they wrote that they responded that they use cannabis to help them with pain, with mental health disorders, with sleep problems, with neurologic disorders, and then a smaller proportion said, for symptoms related to HIV, for symptoms related to cancer, for symptoms related to glaucoma. What's interesting about this is that this is the inverse of the evidence we have about what cannabis might be useful for. This is if you ask patients. What if you ask researchers? If you look at clinical trials of cannabis use, which admittedly have been slow because of all the barriers that exist to studying cannabis, particularly in the United States, you see that there's evidence of efficacy. So we separate efficacy from effectiveness. Efficacy means you see some kind of effect, that it might be helpful. Effectiveness is that something produces a clinically meaningful change for a patient. So you see efficacy for symptoms of nausea, of vomiting, of appetite, of cachexia, profound weight loss, pain symptoms, spasticity, seizures, and then these are conditions: HIV-associated neuropathy, chemotherapy-associated toxicity, MS, spasticity, and chronic neuropathic pain, for which there have been double-blinded, randomized controlled trials of smoked cannabis compared to smoked cannabis that's had the THC removed from it. And what these suggest is that there certainly is evidence of efficacy. And for some conditions, there's evidence, though still on the preliminary side, of effectiveness. However, these are not most of the conditions for which patients, the ones that are doing self-report, are reporting the use of cannabis. And certainly you saw on the prior slide a large proportion of people were using cannabis for mental health disorders, and there's really no compelling evidence yet that cannabis is effective for any mental health disorder. And that's notwithstanding exciting and emerging indications that perhaps cannabis and some cannabinoids might be helpful for PTSD. Those trials are still very, very preliminary, and so there are some areas where there's some interesting signals, but those signals have not moved forward to being really persuasive evidence that this is helpful for clinical disorders. And so consistent with this, and this bottom slide basically summarizes peer-reviewed studies from 1990 to 2012, a 2-decade period of time. It's not up to date, but it basically shows that about a third of clinical trials shows positive effects, a third shows neutral effects, and a third fails to find an effect in terms of does cannabis use, is cannabis have therapeutic benefits for medical conditions. So then if you look at consensus statements from professional associations, you see that by and large they say several things, that on the one hand, purified THC does not, which exists in the form of Marinol, and there's some other formulations of cannabis, dronabinol and Sativex, that are available, pharmacological THC. So purified THC does not replicate the effects of whole marijuana because there's all these other cannabinoids that are in the plant. That there is, in fact, safety and efficacy in some conditions, in contrast to the DEA and FDA's position. That there should be provider and patient protections around appropriate use of cannabis. There should be more research, and the cannabis should be rescheduled down to permit that. And these are statements that have been promulgated by the National Institute of Health, the Institute of Medicine, the American College of Physicians, the professional associations that really help to set the standard for what is best practice on the practice of medicine in our country. They've also said, and this is extracting from some of the professional associations that have detailed the risks, that smoking is not and will never be a safe delivery system for a therapeutic medication, period. That medications should be subject to approval from the FDA. That we have a problem, that the FDA is politicized if it's not making decisions based on the evidence, but the answer can't be having popular initiatives to kind of legislate and regulate medical therapeutics, right? We wouldn't want a popular initiative process to determine what should be like the medication regimen for a heart attack. Doesn't make sense for cannabis either. And that if prescribed, physicians must adhere, and this has been a big problem in California, must adhere to good medical practice, right? A good faith history and physical, treatment planning, informed consent, monitoring, documentation, putting out a sign and seeing somebody for several minutes for $15 to give them a marijuana recommendation is probably not good medical practice, right? Some people disagree. Okay, so next, cannabis is harmless, right? Isn't it harmless? Actually, if you look online, what cannabis' health effects, you will find so much information suggesting that cannabis has no harms. And in the prior, I extracted this from the prior initiative that we had in California before Prop 64, Prop 19, which was the previous cannabis legalization law, narrowly failed to pass in California, but in its findings, intents, and purposes section, right up front, it said cannabis does not have any long-term toxic effects on the body. So this notion is really widespread. And of course, we have the characterization of marijuana as medicine, and medicine can't be harmful. And then other indirect signaling around marijuana safety, right? One of the main ones, that cannabis is organic, and surely any herb that's organic can't be harmful, right? Okay. So is cannabis harmless? And if it's not, how do we characterize its harms? And the problem with talking about cannabis as harms and its benefits is the conversations tend to get it's kind of a value-laden conversation. And this is a framework put together by a group of researchers in the UK and Europe that tried to create a rational system for assessing the harms of drugs based on a rigorous process. And what they did, we won't go through this in detail, it's hard to see from where you are, but what they did is they looked at a whole series of different drugs. For each drug, they said, what is the harm that this drug causes to a user of the drug? And what is the harm that this drug causes to others, to non-users? And they broke out the harms in the kind of biopsychosocial model by physical harms associated with the drugs, psychological harms, and social harms to the user and to others. So using that framework for a second, I would say that you could characterize cannabis's harms, according to social, psychological, or psychiatric, and medical or physical harms, though we know those things are all overlapping phenomena. And if you look at the social risks or harms associated with cannabis use, you see that across studies, smoking cannabis, particularly early in life, is associated with low educational attainment, school failure, lack of employment, lower occupational achievement, lower income, and increased rates of welfare dependence. And this finding has come from studies, longitudinal studies that have made really extensive efforts to control for all the confounding factors, such as socioeconomic disparities, that might also account for this finding. And what they, I think, have made a pretty compelling case for, and you can see this on this graph over here, is that the more cannabis that you use, particularly early in life, the worse your outcomes is on these parameters. So this looks at the percentage of people that earn a bachelor's degree by age 25, and over here you see the number of joints, lifetime joints smoked from 0 to 99, 100 to 200, 200 to 300, and so forth. And you can see that the more cannabis, the lower chance of having earned that degree, the chance of being unemployed, between 21 and 25, the chance of being welfare dependent. Okay, what about psychiatric risks? I think there's a wide range of psychiatric risks, but I'll talk briefly about psychosis, mood disorders, and addiction. So with respect to psychosis, first, it's uncontroversial that the cannabis intoxication can produce psychosis. If somebody ingests a large amount of cannabis, it can produce a psychosis that's part of the intoxication syndrome. Uncontroversial. Any of you that work in the emergency department have seen that for yourself. Also uncontroversial, that cannabis use can exacerbate the course of illness for psychotic disorders. It's been shown experimentally that if you take somebody that has schizophrenia and you give them cannabis, you can increase their symptoms, and that cannabis use among people that have severe persistent mental illness, particularly psychotic disorders, is associated with more hospitalization and worse disease course. The thing that's been controversial has been the question of does cannabis itself cause development of the psychotic disorder? And this meta-analysis evaluated longitudinal population studies that were prospective and that sought to answer the question, does use of cannabis at one age predict development of psychosis at a subsequent age? Does it contribute to that? And what they suggest collectively is that the answer is yes. There is an association between cannabis use at an early age and development of a psychotic disorder at a later age. For individuals who had ever used cannabis, the risk of developing a psychotic disorder was about 1.5-fold, and for people that used cannabis at higher frequency, it was about a 2-fold increase in risk. Now, subsequent evaluation, I think I have a slide on this in a moment, shows that a lot of this risk is borne by a small subset of individuals, and those are the individuals that probably have a pre-existing vulnerability to manifest psychotic disorder. And so this risk is not borne equally across the population. There are some people that may not have any risk of developing a psychotic disorder. There are some people, other people, probably those that have genetic predeterminants that are uniquely vulnerable to the psychotogenic effects of cannabis. And this is really important because it's not recognized by a lot of users of cannabis. And when I'm talking to kids, and we'll talk about this later, I mean, if they have a family history of a psychotic disorder, their unique vulnerability to having this outcome is different than the outcome of one of their friends who doesn't have that genetic vulnerability. One other point I was going to make on that, and it'll come back to me in a second. All right. What about depression? And what about anxiety disorders? You can see that for both depression and anxiety disorders, the confidence intervals across these studies are much more likely to cross 1, which does not necessarily show an effect. Again, these are studies that are specifically looking at, does use of cannabis at one age cause development of depression, anxiety. And at this point, we don't have a good indication that they do. This does not mean, however, that use of cannabis doesn't exacerbate these conditions, or it does not mean that use of cannabis does not kind of inhibit or prevent recovery from those conditions. So I have an anxiety disorder, I'm using cannabis instead of engaging in other treatments for my anxiety disorder. How am I gonna fare over time? This does not answer that. A lot of other indications suggest that cannabis does complicate the course of illness for these conditions, even if it didn't independently cause them. And then addiction we'll talk about last. Oh, so this is one of the studies that looked at, that broke down adolescent cannabis users based on the presence of a genotype that is associated with psychotic disorders, the COMT genotype. And you could see that the risk of manifesting a schizophreniform disorder after exposure to cannabis was predominantly borne by people that had this genetic, had this genotype. So this is one of several studies, and we don't have this totally locked down, that suggests that there are specific genes that help to mediate the risk of having an outcome of a psychotic disorder. Right now, the best proxy for that is a family history, because we don't actually know which specific gene. The gene studies haven't been replicated yet, and there are several genes that impart risk for psychotic disorders. How about among frequent users? Asking a different question, not does cannabis necessarily cause depression or anxiety, but is there an association between the two? And you see that among people who use cannabis that are not dependent, that don't have criteria for addiction, there's an increased risk of there's an increased association between having mood and anxiety disorders. And then if you look at people that are dependent users, this is an older study, so it's using DSM-4 language of dependence as opposed to a use disorder, that there's a 15-fold increased risk of having a mood or anxiety disorder. This is another study that looks at the prevalence of comorbid disorders among individuals that have cannabis use disorder. And you can see that among people that have cannabis use disorder, there's very high comorbidities of mood disorders and anxiety disorders. Okay, what about physical health risks? Cannabis smoke, as I mentioned to you before, has many of the same hydrocarbons as tobacco smoke. Tobacco smoke, we know, tobacco use causes increased risk of myocardial infarction, increased risk of stroke. I mean, pretty much every every physiological system that we have, every organ system, and every disease condition is exacerbated by exposure to tobacco smoke. So wouldn't cannabis smoke have the same effects? Strikingly, so far the answer is that cannabis smoke does not appear to have effects commensurate to what we see with tobacco smoke, and we don't understand why. With regards to pulmonary effect, there was widespread expectation that exposure to cannabis smoke would be associated with a lot of pulmonary complications, emphysema, lung cancer. We see some increase in bronchitis, some increase in impaired ciliary clearance, but not the level of lung diseases that we see in tobacco smokers. With respect to cancer, there is some increased uptick in several cancers. There's also some pre-cancer changes that are seen in really heavy smokers, but nothing like what we see in tobacco smokers. So much so that some people theorize, and we don't know this, that there may be anti-neoplastic cannabinoids in the cannabis plant that are somehow counteracting the pro-neoplastic effects of the toxic hydrocarbons that exist in cannabis smoke, but we don't know. With regards to cardiac effects, cannabis is mildly stimulating. It inhibits a little bit of vagal tone. There's some indication that there may be a small increased risk of myocardial infarction in people that are really at risk because they've recently had an MI. There are also indications that cannabis is associated with reproductive adverse effects, with mild growth retardation, long-term risks of executive function. And this is, again, the story to cannabis's effects is that it's subtle. It's not dramatic, which means it's easy to ignore, it's hard to detect, and it takes a long time to manifest. The reproductive health effects of cannabis is really concerning in light of lots of information suggests that pregnant women are using cannabis at higher and higher rates, and that there's a perception of safety compared to other medications that they might use to manage symptoms during pregnancy. And then, of course, there's the brain. There's cannabis's effects on the brain. No question that cannabis causes acute impairments in memory, attention, integration of complex information. I mean, these are some of the reasons that people use cannabis in the first place. The question is, does cannabis use cause long-term consequences on cognitive function and brain function? And there's a fair amount of literature on the role of cannabis in the developing brain, and by and large it shows that cannabis use during adolescence is associated with functional impairments and also with some anatomic and physiological impairments. The functional impairments include problems in cognitive efficiency and problem solving, loss aversion, executive function, attention, processing speed, reaction time. One of the common findings around cannabis use is that when adolescents who are cannabis users are tested, their performance on activities often is similar to what you would expect, but their cognitive efficiency is lower. They have to work a lot harder to achieve the same effect as you would expect if they hadn't smoked any cannabis. So it may be that cannabis subtly affects, and this is after a period of intoxication. We know the effects during acute intoxication, but that cannabis exposure impairs kind of the efficiency of the brain in solving problems. And so the way I characterize it when I'm talking to patients is cannabis does not, will not turn you from an A student into a D student. It doesn't directly impair your brain that way, but it may turn you from A minus to a B plus, or from a B minus to a C plus, or it does have an impact, and at some point, right, that may have a really profound effect on your trajectory, right, especially during adolescence, where even a small impairment, and it can have more profound impairments, even a small impairment can lead to a deviation over time in terms of one's trajectory. There's been one major study, a large study that was really well controlled, evaluating the relationship between cannabis use and IQ. This was in a cohort in New Zealand, and this study showed that cannabis use prior to the age of 18 was associated with a significant reduction in IQ. And the study happened prospectively. These were individuals that were enrolled when they were young and followed over time. So the study was able to show that there was a relationship between cannabis use and these outcomes, and that it wasn't explained by other factors. And the more times they were diagnosed with having a cannabis problem over the course of the study, the more likely they were to have more significant impairments in IQ. This was highly concerning. It hasn't been replicated. It's not an easy study to replicate at the level and with the rigorousness that it was done. But because of the quality of the study and the significance of its findings, I think that it should give anybody pause in terms of what are cannabis's effects on the developing brain. Now, this was all the effects found in this and in other studies essentially evaluate what happens, essentially show that cannabis impairments occur among people that start smoking before the age of 18. There's less indication that people that start smoking after their brains have matured in their mid-20s exhibit persisting cognitive impairments that persist after the period of acute intoxication. Okay, what about risks to others? Of course, there's impaired driving. There's also a variety of other risks that have been characterized. Colorado has documented a significant increase in accidental intoxications of cannabis products. It doesn't help that cannabis might look like a Snicker bar or a lollipop or many other formulations that would cause somebody who doesn't intend to consume it. Questions about secondhand smoke exposure. I was recently in San Francisco at a conference, and I was walking outside the conference hall. And in San Francisco, if you light up a cigarette among a group of people, you will get shouted down, right? People will not stand to get exposed to tobacco secondhand smoke. But there's another standard around cannabis smoke, right? There is cannabis smoke all over the place on the streets, and a very different standard. Interesting. We don't know yet what the impact is of secondhand smoke exposure to cannabis. Questions of, is cannabis a complement or a substitute to other drugs, such as opioids? Does use of cannabis substitute use of opioids, or is it a complement to it? How does use of cannabis impact perception of risk, both the cannabis and other substance use, and there's some other kind of social implications to cannabis use. With respect to driving, it's been demonstrated pretty conclusively that cannabis use impairs reaction time, it impairs psychomotor coordination, it impairs tracking ability, it impairs sustained attention. And in meta-analyses of studies that look at the relationship between cannabis use and collision risk, there appears to be altogether about a twofold increase in accident risk associated with cannabis use. So people read this in two ways. A lot of people say, oh, well, nothing like alcohol. Alcohol is a 16-fold increase in risk. But this concerns me for two reasons. One is there's widespread perception that cannabis is fine for driving, and given the prevalence of cannabis use, and people don't really argue that alcohol is not good for driving. That's generally accepted. But people do argue that they can compensate for cannabis effects. And there's widespread notions that people are able to compensate. They're not aware of the subtle ways in which cannabis is actually impairing their ability to react to the unexpected while they're driving. Okay, so sizing all this up, the group that I told you about that designed this rational system came up with this. This is the output of their analyses. And what you see here on the x-axis is all the different drugs that they characterized, and on the y-axis, the overall harm. And all the colors here, the bands, represent the different specific morbidities and mortalities that they characterized. The reference is there for those of you that are interested in actually seeing the fine print there. This basically simplifies that graph, funny slip, and breaks it down to the blue, which is harm to users, and the red, which is harm to others. And you can see that cannabis is about right there in the middle, kind of run of the mill over here, after a lot of what are sometimes characterized as the hard drugs. So what I like about this, what I think is useful is, hey, here's a rational approach to trying to assess the risks of a drug and try to inform policy about that. What I think is misleading about this and these kind of representation is they kind of average the risks of cannabis, whereas in reality, and this touches to what our challenge is as providers, is that the risks of cannabis use are concentrated in a minority of cannabis users. And we're often trying to figure out who is within that minority, who is in the vulnerable population that is at risk and most at risk to cannabis's harms, and how do we educate them and help them? So I think the averaging of cannabis's effect kind of minimizes its harms. Well, is cannabis really addictive? Again, from Prop 19, it was in law. It said specifically cannabis is not physically addictive. A lot of notions and misinformation about cannabis's addictiveness, and for people that think it might be addictive, they tend to say, hey, well, okay, but at least it's not crack, right? There's just, so is it actually addictive? Well, it is, and I like to present people 4 lines of evidence that you can use to establish that cannabis is addictive, and that you can subject anything to kind of this test. And it's helpful, I think. I sometimes go through this with patients that I see when we're talking about the evidence. I find with cannabis, you often need to engage somebody in hearing their evidence and kind of presenting yours, so that you can bring them around. It does not work to just kind of lay down a one-directional answer to what their problem is. The 4 lines of evidence. People also, when they think about what addiction is, there is clearly a different lay understanding of what addiction is to how we use the term, clinically. So, anyways, you can use this framework for anything, for chocolate, for exercise, or for drugs of abuse. I would not classify the former as addictive disorders, even though they may have elements of compulsivity and sometimes loss of control. So I would say 4 lines of evidence that we use to establish that a disorder is a disease, right? Addiction is a disease. One is neurobiology, And cannabis, like most other, not all, but most other drugs of abuse, does potentiate dopamine release in the nucleus accumbens, which is sometimes known as the pleasure center, but we actually, probably more correctly, it's characterized as the salience center or the importance center of the brain. And it's important because when something triggers dopamine release in this area, it activates a lot of other brain circuits that are involved in inhibitory control, motivation and drive, memory and learning, affect and stress, to ensure that that event can happen again. And repeated exposure to stimulus that increase this essentially, hijacks or alters parts of the brain over time in ways that that unconscious brain activity starts to govern, the conscious or cognitive control over behavior. In preclinical studies, so these are animal studies, initially scientists found that it was tough to get animals to self-administer cannabis, and they thought, well, maybe it's not addictive. There are all these, experimental paradigms, right? You can give a rat a little bit of cocaine, right? You could give it to it directly. You could infuse it and see if it presses a lever, that lever administers more cocaine, whether it will press that lever over other levers for food and water sustenance. In the early studies of things like cocaine, it was pretty remarkable. Those rats would press and press and press and press until they died of exhaustion, right? So cannabis was not quite as dramatic. Initially, animals didn't want to self-administer it. Perhaps they felt, paranoid, socially anxious, uncomfortable. You had to coax them, give them repeated exposure, and then they started to like it. And then they would self-administer it, or they would gravitate towards parts of the cage where it was available, and all these other experimental paradigms that show that, yes, cannabis is reinforcing the way other substance use disorders are. There's, of course, a clinical syndrome. This is the DSM-5 criteria we'll talk about in the second half of the talk. And a pretty consistent epidemiology where cannabis is available. You see kind of similar rates of cannabis use disorder and cannabis problems. So this is not just a cultural issue or issue that's relegated to Torrance or Los Angeles or California or the U.S. In countries that make cannabis available, you see cannabis use disorder. Okay, what about tolerance and withdrawal? Right? Tolerance is neither necessary nor sufficient to make a diagnosis of addiction, but it's what a lot of people associate with substance use disorders. So I do like to present this. This is a rat brain that, again, has been stained for cannabinoid receptor. And this is a rat brain that has been chronically exposed to THC and then is stained for cannabinoid receptor. And you could see a profound difference, right? The brain has changed. It's adapted to that constant exposure. And that adaptation to exposure is part of what drives and that neuroadaptation is what tolerance is. And then, of course, there's a withdrawal syndrome that has now been pretty well characterized, and is characterized by common symptoms such as irritability, aggression, restlessness, changes in appetite, sleep problems, nervousness and anxiety, and then some less common symptoms. I have a more updated version of this that somehow didn't make it, that includes the hyperemesis syndrome and some other less common withdrawal phenomena. But this is one of several studies that was done by Alan Budney, who helped to really establish that the cannabis withdrawal syndrome is a legitimate syndrome. And in this study, subjects were paid to use cannabis for a period of time, and then in a monitored way to stop using cannabis for a week at a time. Use for a week, stop for a week. And what they showed conclusively is that when they used, their withdrawal symptoms went down. And when they stopped using, their withdrawal symptoms went up. And they used again, and then they went down. It was a nice kind of proof of concept, right? Cause and effect there. And what's interesting, and I think why this is so important, is that when you ask people why they smoke cannabis, why is it helpful? What's it helpful with? Well, it helps me sleep, helps make me more calm. Yeah, it improves my appetite. It improves my mood is like a little more. They may be and probably are treating their own withdrawal symptoms, and they're right. They're right. Those symptoms are going down when they're smoking, right? But that's also the problem. And so sometimes it will actually present to them, especially the ones that are interested, this evidence to help them reframe and recontextualize what their own experience is. I think this validates their experience. as opposed to them telling me what it's helpful for and me telling them that, that it's just withdrawal symptoms. Now, the other thing that's interesting is if you compare cannabis withdrawal severity to tobacco, to nicotine withdrawal, you see that the severity levels are about the same. This is on a 3-point scale. You see most of the severity of these symptoms is about, a level of a 1, right? So this is not a withdrawal syndrome that's going to, drop you on the ground and you have to lock yourself up and, suffer through some hair-raising withdrawal symptoms. You can almost not notice that this is happening, but it's like Chinese water torture or something. It's a really strong reinforcer to continued use, right? And it's sometimes that subtle not feeling good and wanting to feel a little bit better that is as significant driver as a more dramatic withdrawal syndrome. All right. So with that, I think we are at the halfway point. Why don't we stop for a break? All right. A couple things before we move on to the next section. First, a bunch of you asked for the slide deck. What I'm going to do is make sure that Mo Gelbart has the slides, and is that okay? Yeah. Is there a central way to get them out to you? So they're available to all of you. Second, before jumping into the next session, I thought it might be useful to take 5 or 10 minutes for questions. There were a lot of questions, and I'll try to keep it to just under 10 minutes so that we definitely have time for the second portion of the talk. But if there's any compelling questions or if anything I said was confusing, then please let me know.
And please wait for the mic. Makes it easier.
Thanks. I work here. So you're really great. Thank you. Thank you.
Oh, thank
I
you.
was curious more about different rates of transmission. Since e-cigarettes, the vaping, and is it stronger? How do you have to use an oil? Because people come in and I don't know much about it.
Okay.
Or the risks about it.
Yeah.
Okay.
So the question is about vaping, and I got some questions during the intermission about vaping too. So what vaping is a mechanism to vaporize the constituents in cannabis, so that at a kind of lower heat point, they can be vaporized and absorbed without some of the hydrocarbons that are in tobacco smoke. So instead of generating a smoke, they heat things to the point where there's some vaporization of the cannabinoids and some of the other stuff that's in cannabis, but not as much as you get with a smoke. There's a perception that they're more safe. It's probably true that vaporizing does expose you to less of the hydrocarbons than you get in tobacco smoke. You can vaporize the buds and leaves. You can vaporize oils and waxes. There's a lot of different vaporizing systems. There's not a lot that we know in terms of the science and literature about effects of vaporizing, and people can adjust their use of vaporizing to get varying levels of intoxications and exposures. We do know that people are getting exposures to concentrated THC that was really hard to get previously with smoked cannabis. And there's a lot of concern around both the perception of safety with these devices and just the kind of like enthrallment factor and cool factor with these devices. I have 3 small kids, and one of them is in middle school, and is a big concern around her school and my, and local schools. I give a version of this talk to schools in LA on how to regulate vaporizers, both for vaporizing tobacco and cannabis, because some of these vaporizers look like thumb drivers, and and kids are bringing them onto campus, and it's very hard to regulate, and they don't produce a smoke that has the type of odor that is as easily identifiable as tobacco or cannabis smoke. So a lot of challenges and a lot of questions. Certainly, and finally, though these products have the appearance of being regulated, they may specify constituents, within them, and there's very poor regulation on both what the specific cannabinoids are that are in the substances that are consumed and the other chemicals that are in these substances. So the safety of these devices and the safety of the compounds that the devices are helping people consume is not established at all. And I think that the greatest concern, it's a concern for everybody, but particularly the vulnerable populations I characterized before: youth, people that have a vulnerability to having a mental illness, and pregnant women.
So a little bit more on the vaping. I'm finding that a lot of adolescents that are trying to stop vaping cannabis are switching to doing vaping juice with the vape pen. So I'm curious as like what your thoughts are on using that as a replacement for trying to stop cannabis vaping.
Right. So, what are my thoughts on using vaping? Vaping, kind of a less harmful substance than cannabis, as a way of kind of getting off the substance. I think that in my role as a clinician, I try to put aside my personal opinions, which I'm happy to share with you, and say, well, what does the evidence tell me? What can I draw from my my understanding of the literature and for the evidence that does exist, how high quality is the evidence? So I don't think that there's any evidence to suggest that those are useful strategies, even though they're kind of rational strategies. They sort of make sense. I think that the concerns I would have is, on the one hand, using something less harmful is better than using something more harmful, but perhaps it's not just the drug that's reinforcing, perhaps it's the habitual activity, right? And as you replace one habitual activity with another, if you're not doing something else to address the root cause, the issues that are underpinning, all of this, then, are you really getting to the underlying problem, or are you just, kicking something down the road? So I wouldn't recommend that. Now, if somebody did it, I think for all drugs, and particularly for cannabis, as a clinician, you have to have kind of a high tolerance for, what the patient is willing to do on their terms, provided it's within certain parameters of safety. And so I think it's a different question on how you manage that as a clinician, but I try to be clear and consistent that while I respect the kind of unique beliefs and perceptions that the patient has, I might respectfully push back on him, that my role is to bring like what my evidence tells me.
You mentioned that adolescents that are smoking show cognitive impairments. Is that permanent, or is it possible, like, if they quit at a certain point in adulthood and start exercising regularly, or meditation, or any other kind of holistic approaches, that they can combat these deficits?
Yeah, I think that's a great question. The question is, do you get persisting impairments in cognition? I think that there's evidence to suggest both. There is evidence that there are some studies that show that there are persisting impairments that persist after the, all the studies, the quality studies of cognitive impairment evaluate people 1 month after smoking, so that because they want to disentangle intoxication and withdrawal, both of which can affect cognition. So there are a fair amount of studies that show persisting impairments in cognition even after that period, and there are other studies that suggest that that those impairments of cognition diminish over time and become imperceptible. My guess is that there's significant improvement, and perhaps for some individuals there's normalization or kind of imperceptible differences, but I think that it's overly idealistic to say that perhaps there'll be no consequences at all, particularly of heavy use. There is a dose-response relationship on all this stuff, and so I do think that the infrequent experimentation is fundamentally different than heavy exposure.
Okay, hi, I'm going to go first, I guess. I have a two-part question, if you don't mind.
Okay,
The
why
first-
don't we'll take yours and one more, and then we'll lead in.
Okay,
Okay.
great. The research that you presented, was it focused on receiving the THC simply through smoking, or did it include any other types of,
Well, I presented lots
ingestion?
of different stuff. The preponderance of it was based on studies that looked at smoked marijuana, not all the other routes.
Okay. And then is there any current or more recent research done on the combination of CBD with THC and other methods of delivery, edibles, sprays?
So the answer is yes. In the kind of pharmacology and the clinical trials space, evaluating cannabinoids for various medical indications, there is a product called Sativex, which is 1-to-1 THC and CBD that has indication for several conditions, and it's an area of a lot of interest. Again, as I mentioned at the outset, the focus of this talk is not the therapeutic applications of cannabis. That's a whole other talk. And there are a lot of questions about which cannabinoids, CBD and others, do you need to get the therapeutic benefits? But different day.
What was the
Right here, sorry.
term you just used?
Sativex. Sativex is the name of a compound that is, it's a pharmaceutical compound that is THC and CBD.
So a while back, I remember seeing some sort of an article about fertility, like couples having trouble conceiving, and they saw that the males using pot, that they thought there was some correlation. Do you know anything about the fertility literature and use of pot?
Yeah, I don't know a ton about it. I think it's another space where I know that there's been some signal, but not great evidence. And I do know that in preclinical studies, there have been relationships that have been shown between cannabis exposure and like sperm motility and all the apparatus that are involved in reproductive physiology, both on the male and female side. So there's a lot of reason to think that there may be an influence on actual on real outcomes, but I don't think there's a lot of evidence for it yet. Okay, so with that, we'll launch into a case, and I want to do two things. We only have about 30 minutes for it because I want to leave time for questions at the end, and I want to encourage you to ask questions in the middle of this so we can make it a little bit more interactive. I don't want to be as slide bound as we were the first route. And the case is the following. It's a case of Kevin. Kevin is a real person. He's a 20-year-old male. He was a college sophomore. He was using cannabis on a daily basis. He received a D. His parents were aware that he was smoking cannabis. They were concerned. They had negotiated with him about it. He seemed to be doing fine. He wanted them off his back. He was, in college, and they didn't have the same level of oversight. They were struggling. Now with the D, they were like, all right, you got to have this evaluated. They had actually seen a version of this talk at a local high school where they had another kid, and they thought, maybe we can get you to. I think they asked me, can you talk to our son and tell him that it's. I said it's a little more complicated than that. But Kevin began using at age 15. He'd experimented with a variety of substances. At some point, he intensified his use to the point that he was using about a 1/4 ounce of cannabis every 2 weeks. He then switched to oil, which he was using about 3 to 4 times a day. He reported, that he had some ruminative worries, some social anxiety. He had some difficulty sleeping. He thought the cannabis was helpful. No personal or family history of a psychotic disorder. No personal history of a major mood disorder. Again, marijuana he found helpful to relax, helpful to sleep. In terms of harms, his own harms associated with the cannabis, he didn't really attribute the D to the cannabis. He thinks that he's able to compensate okay. He did acknowledge that his first serious girlfriend had broken up with him, and she thought he was getting high too much, that he wasn't available to her, and he was concerned about that. So anybody ever seen anybody like Kevin? I think what's unique about Kevin, and here's what Kevin doesn't have. Kevin is not a returning veteran that is suffering from PTSD, and he's not suffering from pain. He's not also on opioids, and Kevin doesn't have psychotic disorder, and Kevin doesn't have school failure. At this point, Kevin doesn't have a broken family system. Kevin doesn't have many of the other adversities and challenges that we see day in, day out for the people that are presenting with cannabis use. I mean, most of the people at Cedars-Sinai that I see with cannabis use, in their view, it's the least of their problems. They might acknowledge it as a problem, but they have many other things that seem to be more primary. And frankly, even if they are acknowledging that they have an opioid use disorder, an alcohol use disorder that they want treated, cannabis is a separate conversation, right? So I like to start with the simplest because what helps Kevin, and then we can add in, and you can add in all the complexities that we face day in, day out, and think about, okay, well, how do we manage that in this? But what I would contend is that even though Kevin is like bread and butter about as simple of a case presentation for a cannabis use issue that you could have, that every component of the assessment and management of him is actually quite challenging. Establishing a diagnosis is a challenge. Persuading Kevin that he has a diagnosis, if I think he does, is a challenge. Assuming he agrees, okay, yeah, cannabis is a problem. I don't have control of it. Okay, yeah. I mean, setting goals is a problem. What are you going to do? Are you going to reduce use or stop use altogether? Developing a plan to implement those goals is a challenge, and then staying on course, is a challenge. Now, it is for all substance use disorders, but I think that cannabis brings some unique challenges to it. So why is establishing a diagnosis so difficult? Well, for one thing, when you talk about alcohol, it's like, beer, liquor, wine, and with cannabis, we have this incredibly rapidly evolving dynamic field where what is cannabis is evolving greatly, right? Is it the oil? Is it, well, what about the percentage of CBD and what, okay, THC is bad, but if you mix this, I mean, there's so much to that. You get in this like relativistic thing about what is cannabis. So the thing that we talk about when we're talking about cannabis is a little bit of a moving target with all these different formulations ranging from the loose leaves and buds to vaporizing. That's what one version of what a vape pen looks like, to consumables. Another thing that makes it challenging is that trajectories of cannabis use vary widely. And we all know this. This is a study that nicely illustrates what you all know probably from experience. This was from a research group who evaluated college-age cannabis users like Kevin over a 7-year period of time. And what they did is they characterized their use of cannabis, and they characterized a variety of social, psychiatric, and health outcomes for each of them. And then what they did is they described several types of trajectories. They categorized the trajectories of cannabis use of their groups into people that were chronic heavy users up at top, people that used a lot in college and then stopped afterwards, attenuated their use, people that didn't use much in college but towards the end began to increase and after college continued to increase, people that used a little bit and then declined, and then people that used small amounts throughout, or then those that didn't use at all. And without getting into the details on this, I think what was interesting about this is that the folks that had the best health outcomes were the people that had the low use and the people that peaked and that stopped after college. And the people that had the worst outcomes were the chronic users. But there were also, the differences in outcomes across the groups were kind of subtle. And the notion is that it's hard. What we have to do, Kevin shows up, we're at a cross section here, and we don't know what course he's on. Is he on this course? Is he just like beginning to peak and getting worse, or is he going through this kind of developmental stage and coming off of it? We don't know, and I think that makes it challenging for us to determine what's going on. Also, drug testing doesn't help us answer the following questions, and these are some questions that I'm asked all the time, and it's frustrating. Look at the cannabis test. Can it tell us how positive Kevin is? Is his level of THC a high level? Does that level means that he's not fit to work, to study? And, can he, if he's a parent, can he parent? I gave a version of this talk to a judicial society in one of the large judicial meetings. The judges were all struggling with this, and they're like, give us a level. Can somebody, be fit to parent? And sorry, you guys are used to dealing with gray zones, I hope. How recently did they use? Are their levels increasing or decreasing? Is this level, from new drug use or from, past drug use? Why are these so difficulties? Well, there are some technical issues around measuring THC concentrations and drug levels, the sensitivities of the assays and the kinetics of the tests. There's also some physiologic differences. You get different levels of THC in the urine depending on how much total urine output you have. There's elimination of different drug components, the different endocannabinoids, and different detection periods depending on how frequently cannabis is used. The endocannabinoids are lipophilic. They get stored in adipose tissues. And if you just smoke one time and then drug test, it should be out of the system in 1 to 3 days. If you smoke heavily, it can last in the system for 4 to 6 weeks because there's deposition in the tissues. Now, the reason you can't establish levels and know if something increasing or decreasing is because activity and level of hydration and consumption of foods and all those things can alter levels in a way that make it difficult to get the kind of causal relationships that people want, even though there are some ways to trend things out. So how do you make the diagnosis? Well, as you know, DSM-5 fortunately combined abuse and dependence into one concept, and that concept is called a use disorder, substance use disorder. And cannabis use disorder, like all other substance use disorders, is characterized by a maladaptive pattern of use leading to impairment or distress, right? That's necessary. There's got to be some impairment or distress for us to believe there's a valid disorder there. And it's characterized by 2 or greater of the following within a 12-month period. And there's 11 criteria. I like to group them into physical dependence, loss of control, compulsivity, and harmful consequences. And DSM-5 now has a severity indicator where out of the 11 criteria that are grouped over there, the more criteria you have, the more severe your disorder is, which is nice and intuitive. Physical dependence is asterisked because it alone, it's neither necessary nor sufficient for a diagnosis. And if any drug is administered under medical supervision and in accordance with that supervision, then those criteria don't count. Okay, so let's assume that we have evaluated Kevin. We think, actually he has lost control. He's taking more and more over time than he intended. He's made some efforts to cut back. He tried when his girlfriend expressed concern about it, but then he ultimately resorted to his use. He spends a fair amount of time, using cannabis. When he doesn't have it, he craves it. We think he's got a use disorder. Now, how do we persuade Kevin? Well, we run into this issue, right? Kevin thinks, all right, well, maybe it's a problem, but there are worse problems, right? And this one's not such a big deal to him. So how are cannabis users different from users of other substances? And, this is not whole-scale differences because these issues all, are common across substance use disorders. But for cannabis in particular, there's this notion of perception of benefits with cannabis that is different than other substances. There's been a profound reduction in assessment of risks associated with cannabis, and the information around therapeutic effects of cannabis and recreational use of cannabis is totally conflated, where it's hard to have a conversation about one or the other because you talk about cannabis use disorder and it quickly goes to, well, isn't it helpful for X, Y, and Z? There's, of course, a social movement and so much advocacy around cannabis. For some people, there's a spiritual resonance to their cannabis use. It's deeply important to them. And even when people acknowledge that cannabis is a problem, they're much less likely than users of other substances to endorse a goal of abstinence. Usually, they are only willing to endorse a goal of reduced use. So, your challenge, and this isn't Kevin, but this is another, young person, and your challenge is as parents and as providers is, on the one hand, there are these short-term risks that concern, that a user of cannabis is often kind of can acknowledge. Cognitive function, substance-induced symptoms, toxidromes, motor coordination, the impact on, there's nobody that really disagrees that it's not good to study while high on cannabis, right? The short-term effects are just not controversial. There's the long-term risks, right? And unfortunately, it's one of life's big jokes on us that it's like when we're most vulnerable to some of the long-term risks, it's when we're least capable of considering long-term, risks over the short-term things that we know. And the long-term risks are some of the things I characterized in the prior session around cognitive impairment, long-term risk of addiction. About 1 out of about 1 out of 11 people who were exposed to cannabis, 1 out of 10, depending, from 9 to 11 of people who are exposed to cannabis will develop a cannabis use disorder at some point. There's all the information about health outcomes and social outcomes that are the long-term risks. Talking to young people, it's very, very hard to leverage concerns about the long-term risks. Most of the conversation that they're receptive to is on the direct stuff that they're able to identify. What about setting goals? Right, I put this to acknowledge it's much easier to be the one wielding the axe than like the other guy. How do we deal with recommending change and setting goals with our patients? I think that as with all substance use disorder, the trans-theoretical model of change, right? The notion that people just don't instantly decide to commit to a course of action. Okay, I'll totally abstain, but that they go through their own process of beginning to consider that something is an issue and preparing to make a change and then committing to a change and sustaining it is critical. It's critical because the way we interact with patients is very different as we see our role as, hey, let's move somebody from pre-contemplation to contemplation as opposed to moving them from pre-contemplation to action. And if Kevin shows up in a pre-contemplative state with his main chief complaint being, my parents are on my back to have me come here, and he's looking for confirmation that actually he's fine, and I come in suggesting an action, then we're just going to get a mismatch, and you all know that. Of course, there is the principles of motivational enhancement therapy about giving direct feedback regarding personal risk or impairment. That's why, particularly around cannabis, particularly with young, bright, intelligent people that are engaged and have strongly held ideas about cannabis, I like to engage them in a conversation. Show me your evidence. Let's evaluate what is going on here. And I think it's also helpful to get them to be critical and skeptical of the cannabis industry that's emerging. Because one thing is common to kids, they don't like to be manipulated by industry. And I find that that's sometimes a lever that can help us get aligned in trying to understand and evaluate what information they're looking at. Responsibility for change is ultimately the responsibility of the patient. We try to give advice in a clear, non-judgmental manner. We try to give options. We try to put options in front of them that are therapeutically oriented options. So I'll often have a kind of priority list of what my top options are, but all the things that I can accept offering, and then I draw the line at some things that I can't endorse, even though perhaps they'll be helpful, like some harm reduction interventions, as were asked about at the prior question. Having an empathic orientation is key. Cultivating a therapeutic alliance, aligning with the patient point of view, and engendering self-efficacy is clearly key. We may have time to talk about it a little bit when you look at studies of interventions to treat cannabis use disorder. The studies that show the most effect are the psychosocial studies that look at contingency management and CBT and motivational enhancement. They all show, when they look at what's moderating the effect, is that sense of self-efficacy, right, is critical. And any way that you engender a sense of self-efficacy in somebody, you're more likely to help them be successful committing to a course of action. Developing a plan. Who here is familiar with the ASAM criteria? Have you heard of those? Some of you. So ASAM is the American Society of Addiction Medicine, and it's been engaged in a multi-decade process to try to bring evidence and standardization to the process of determining what level of care somebody should be at, rather than residential, oh no, that outpatient, just like, oh, okay, because I said so. Like, well, how do we actually determine that that is the appropriate level of care? Right, if I want to get somebody to the ICU at Torrance Memorial at Cedars-Sinai, there's some like specific indices. Now there are wobblers and points where we may have disagreements, but there's a framework for determining what is medical necessity. So how do we bring that to substance use disorders? It begins with taking an assessment of a patient. And what the ASAM criteria does is it formalizes an assessment methodology for assessing a patient, and then it applies evidence towards, at varying levels of severity, what level of cares are justified and have evidence supporting their application. And this roughly conforms to the biopsychosocial model, these dimensions. So you assess somebody's acute intoxication or withdrawal potential, right? That's very important. Are they at risk of an imminent severe withdrawal? If they're at risk of DTs, that's going to drive that hospital admission, right? It's rare that withdrawal risk or from cannabis is going to drive the need to be in a detoxification. Biomedical conditions and complications, right? Emotional, behavioral, cognitive conditions, that's all the psychiatric components. Readiness to change is a key dimension. Relapse potential, continued use or continued problem potential, and then finally the recovery and living environment. These are felt to be some of the accessible factors that help us determine what somebody's risk of relapse is and help us tailor treatments at particular level of cares. Now, level of cares occur across a continuum, you guys know, from early intervention and prevention to outpatient, intensive outpatient, partial residential, clinically managed high-intensity residential services. I know each of you live in a setting where each of these levels of care are readily available to you, and you have the full continuum. You can get anybody access to them at any point you need and they want, and it's covered by insurance. These are, just so you have it in the slide decks, the characterizations of what's in each of the levels of care, right? What's in outpatient? What's in IOP? What specifically differentiates it? And this is all in the ASIME criteria for those of you that choose to learn more about that. It's nice because it really provides some clear information about what is what when we're talking about levels of care, and so we can make more informed decisions. Okay, what interventions are going to be helpful for Kevin? These are psychotherapies grouped based on whether they are individual, group, family and systems, community intervention. MET is motivational enhancement therapy. CBT, cognitive behavioral therapy. Contingency management, right, is having rewards or punishments contingent on certain behaviors, like producing negative urine screens. And SEP is supportive expressive psychotherapy. Probably the least evidence, but perhaps one of the most practiced forms of psychotherapy in outpatient practice. I put it on there because the absence of, the fact that it hasn't been studied as much doesn't mean that it's not a valid and viable consideration there. Most of those interventions have been done in group formats as well. There's some specific models for family and systems intervention. CRAFT, MDFT, multidimensional family therapy, or well-established evidence-based interventions, and then community interventions that are often used: Marijuana Anonymous, 12-step, therapeutic communities, sober livings, but for which there's really not much evidence for. It doesn't mean, again, that they don't work, just not been studied. Not easy to study either. So looking at the psychotherapies at large, what are the take-home points around them? So studies that evaluate what about these psychotherapies work show that there are many features in common. So whether you're in CBT or contingency management or motivational enhancement, you have a defined entry into treatment, you make a commitment into change, you set some goals, you incrementally move forward solving problems, you focus on relapse prevention, you monitor somebody's effect over time, and you have a defined closure. It turns out that's powerful no matter what specific therapy you're offering. External reinforcers are really helpful with early abstinence. So Kevin probably wouldn't have come in my office without his parents, driving it. And for cannabis, it's often somebody else, the wife, the husband, it's often another concerned party that is pointing out that there's an issue. Contingency management procedures that promote continuous abstinence. So, paying somebody for a clean urine, or giving somebody a reward, a gift card, or enabling somebody giving them access to their allowance or to their trust or what, it helps them achieve abstinence and perhaps shows them that they can be abstinent, but it's only as good as long as you have that inducement there, right? So you need something else to help somebody develop skills to maintain abstinence once you take away that reward or that punishment. Across different interventions, self-efficacy and coping skills are what predict improved outcome. So, changes in self-efficacy in studies and acquisition of skills is what predicts improvement, regardless of what type of intervention somebody's in. There's also, it's not here, but there's, the early studies evaluated these psychotherapy interventions separately, but later studies combined them. And there's good evidence that using contingency management to help create some external reinforcers, using motivational enhancement to help engage somebody and being willing to commit to change, and navigating the turbulence that arises, using CBT to develop skills around relapse prevention, and using supportive techniques, that all of these things work well together to provide a kind of comprehensive therapy experience for somebody. There's a proliferation of digital health interventions, right? Get online and get some treatment. And perhaps these hold a lot of promise that they're going to overcome barriers around access, around stigma. I could do this in the privacy of my own home, around cost, around having a standardized quality intervention. I think that this is inevitable. It's not here yet, at least in a way that we have evidence for, though there is a tremendous growth of companies that are offering these services. And that report that they have good outcomes. There's not a really good objective basis for assaying them, but I think that this is a really exciting area of the field. Okay, I think I summarized this evidence for you, so I won't go through it again. What about medications? A variety of medications have been explored for cannabis use disorder. Cannabis agonists, cannabis antagonists, opioid antagonists, antipsychotics, antidepressants, mood stabilizers, anxiolytics. The bolded medications that you see there are the ones that have shown some efficacy for one thing or another, but none of them really show consistent effectiveness. And so nothing is FDA approved for the treatment of cannabis, and I won't, unless there are questions on these, since I think we have a minority of physicians in the audience, I'm not going to belabor all of this. I think there's a fair amount of symptom management, of symptoms associated with withdrawal, but again, that's in the space of kind of empirical care, and there's not great evidence-based standards guiding medication use in cannabis. All right. Once you commit to a course of action, you got to stay on course with it. I use this, this cartoon to basically remind myself, and ourselves that, though we sometimes we're in the position to see addiction across this cross section. It's a chronic vulnerability that happens, with a long arc. And for those of you who have been in practice a long time, for me, the longer I'm in practice, the more I'm humbled by people that I thought were doing great that don't do well, and people that I thought were, heading down south that end up, doing terrific. It's our job to try to help them along that way, at each point. And I think that trying to recognize, even though it's imperfect, where they are along their own continuum helps us tailor specific interventions to where they are, because the same thing doesn't help when somebody is trying to maintain recovery as what needs to happen when you're trying to stabilize them acutely after a period of use. And all of you who are in a intensive treatment program for substance use disorders recognize how different somebody is in the first several weeks to first several months to a year out of use. Our challenge, as you know, is that as a society, we tend to think of addiction in this kind of cross-sectional way where we'll look at exposure to addiction treatment. We'll say, hey, there was a lot of use prior to treatment. They were in treatment. The use went down, and they left treatment, and the use returned. Right? Therefore, addiction treatment wasn't that effective. And we know that for chronic diseases, that's the wrong model. If you look at a medication treatment for hypertension, and the antihypertensive works when the patient's taking it and stops working when they're not taking it, what conclusion do you make? Right? That they need more treatment. This slide comes from McClellan, who's used this paradigm to make the point that addiction is we have to bring a chronic disease framework to thinking about addiction and offer interventions that are effective over time. And if you look at addiction as a chronic illness, you see that the rates of relapse and non-adherence are similar to many other chronic diseases that require significant behavioral change to achieve optimal outcomes. So, in summary, what I've tried to show you is that first, there are distinct categories of marijuana use. That there's recreational use, there's self-medication of marijuana use, how people medicate themselves. There's medicinal use, which I define as use under the supervision of a physician providing appropriate care. There are certain populations that are particularly high risk for cannabis-related harms: youth, people with severe persistent mental illness, people that have other psychosocial disparities to begin with, risk of substance use disorder. Cannabis use disorder is not defined by a quantity of use. Do you use oil or wax? How much do you use? It's defined by the presence of functional or behavioral problems. Also, it's possible to have some negative effects without having the disorder. Treatment works. It requires monitoring. There's a robust evidence base. There are lots of tools that can help provide you guidance around treatment. And harm reduction also works. Harm reduction around educating people on the contents of what's in, what they use, using safe use, risks of combining drugs, the risks around driving, risks around accidental exposures if they have kids around and they're users. In California, we have a lot of questions that are unresolved. We are among several states that are conducting this massive social experiment. How are we going to ensure that as we commercialize and legalize wide-scale access to cannabis, we protect at-risk populations? How are we going to ensure that for people that develop cannabis use disorder, they're going to have access to treatment, that it's going to be available, accessible, and it's going to be of decent quality? How do we ensure that products that people use, that the contents are what they say they are, that they're not contaminants in them, that things are labeled appropriately? How do we ensure that the industry, the cannabis industry, has oversight? A cannabis regulatory board was established by AUMA for California, but it hasn't had time to finish forming. And meanwhile, there was a statutory requirement for commercial sales to start in January. So commercial sales have started before the regulatory mechanism to control them has really matured. How do we ensure that there's adequate monitoring around driving, around safety-sensitive professions, like what all of you guys do? How do we ensure that there's research, right? We're in this massive social experiment. Can we evaluate the impact of policy, the effectiveness of prevention interventions, and given that revenue is driving so many of these policy changes, how do we ensure that revenues, taxes that come in are first allocated to address these above goals, right? That's actually in AUMA specifically allocates revenues first to the regulation activities and second to the prevention activities. But there's already a land grab to try to get a hold of all these revenues. We are in the position of the blind leading the blind, and lots of resources that are available for you, and you can Google them online, but here are some resources as well, and lots of references through which you can get into the detail on this. Both CSAM and ASAM have wonderful resources online around cannabis, and then several of the federal agencies, including NIDA and SAMHSA, have really outstanding resources that are oriented towards providers, resources that are oriented towards laypersons, resources that are oriented towards youth. So if you're interested in this, really encourage you to go on some of those sites and pull the tools and toolkits. Thank you, and I think we have 10 minutes to round out with any questions.
Thank you. This has been wonderful. Great information. Thank you.
You're very welcome.
I'm wondering about the chemicals. We often hear that there's 400 to 600 chemicals in marijuana, and I'm wondering about those chemicals, not listing off what they all are, but the impact and what they are an impact to health.
Yeah. You know, so when you burn an organic compound and generate smoke, you get all sorts of hydrocarbons. And if you had other constituents on that organic material, such as pesticides, you know, and then you get all those. And as you burn them, they change too. So, you know, smoke is a really complicated entity that has many, many different constituents. The term hydrocarbon is kind of a shorthand for all the different variations of things that can be in there. For tobacco smoke, we understand that nicotine itself drives addiction, but nicotine itself is not in low doses is not physiologically harmful. That's why you could take nicotine replacement in and of itself. There's no significant health effects. It's the smoke that comes with the tobacco that carries a lot of the risk. So a lot of the same hydrocarbons that's in tobacco smoke are also in cannabis smoke, and it's been surprising that we have not observed the level of physical health adverse effects out of people smoking tobacco smoke that we'd seen people smoking cannabis smoke as tobacco smokers. And there were these, you know, early on there were these studies of like, you know, some populations in Jamaica that were smoking enormous amounts of cannabis all day long, huge amounts of smoke, and were not showing signs of having the kinds of health effects that you would expect among people that smoke commensurate amount of tobacco. So we don't know. We don't know exactly what's going on. There are health effects. It may be that they're subtle. It may be that that some of the endocannabinoids counteract some of the health effects. It remains to be seen.
Thank you very much for your talk. A couple of years ago, I chaired a panel on marijuana, and we had a couple of people speaking from Colorado. So at the time, it was a couple of years into their legalization process, and they already had evidence of huge increases in the potency of the product, as well as increases in ER visits for psychosis related problems. Do you have any update on, since they're way ahead of California in terms of legalization, what the latest information is coming out of Colorado?
I think, you know, more of the same. That they have shown, you know, significant increase in ED presentations, significant increase in driving, you know, incidents, significant increase in accidental exposures. What's interesting is that all of the data is argued about by proponents or defendants, right? So some people say, hey, people are picking it up more because they're testing more for it, and prior to all this, they weren't. I think that at face value, there certainly is increase in risk. There's now preliminary evidence coming emerging around youth use that does seem to point in the direction that there is, you know, increased use and increased intensity of use. But there's a long lag to the kind of high quality epidemiologic data. And so a lot of what we have are proxies for the outcomes that we're concerned about.
I was intrigued by something you mentioned a little earlier about appealing to maybe, I think with the case study, when you were talking about how people don't like to be manipulated, particularly when they're younger, by mass.
And when we get older, we get used to it.
Yeah, right. So I was curious, I don't know if you have time to do this, but I was just wondering if you could kind of elaborate a little bit on what that conversation would be like. Like, what do you say to kind of, to someone who's young, and you might find that as a good entry point to have them think about, you know, move to the contemplation phase, or anyway, can you give an example of how you bring that up?
Yeah, the general logic is that somebody comes in, you know, they come in for some type of assessment. Somebody thinks they have a cannabis problem, and it's my job to figure out if there is one, and if there is one, to help kind of bring them along. Because if they're not along, I could think whatever, and the external folks can think whatever, and they're going to fight it and resist it. Doesn't mean you can't still intervene and it won't help them, but it's helpful if they come along. So I think it begins with trying to take their position, on the issue at hand. And so I'll explore what they value about cannabis, and with the notion that anything that you do that frequently has to be important to you, and help me understand what it's doing for you. And that if eventually if they're receptive, to that, that helps me understand their experience of what they value, about it. And then it positions me to be able to ask them kind of rhetorical questions about, well, what are the downsides? What are the upsides? Well, why not smoke nonstop? Are you concerned about any of the health effects? And so the concern, oh, no, you're not. Well, where do you get your information, about cannabis? How do you know that? You look online, people tell you, and and who are the people that, do you get most of your information from your friends or from, get it online? Oh, what can you, and over time, it can't, sometimes a lot can happen in a single session. I find, a lot of the studies of the psychotherapy interventions happen over 10 sessions. With Kevin, actually, it took me probably 8 sessions to get him to commit to, making a change. It was a lot. It wasn't I had to engage him in having in building a therapeutic alliance and wanting to come in. He was more interested in, some of the social anxiety and issues with his girlfriend, and so we took an indirect route to get to the cannabis. That's what kept him kind of coming back in. It's what he wanted help with initially. Eventually, he did it. So that's a long way of getting to. I'll get them to present their information, and then as they do, then we can scrutinize it, ideally together, and say, well, who's promoting that information? Is that coming from? I didn't have time to add it. Somebody had showed me there's a organization with a website that has recently developed that has as its mission promoting cannabis use to end the opioid crisis, which is another issue that we didn't get to talk about. And they have a very sophisticated looking website with all the evidence and literature suggesting that, and it's confusing. You as a clinician, it's confusing. So, we'll take some of that on and try to, understand it together. And I tend not to do that in, probably have a more traditional relation to patients in most other conditions, but I found that especially with youth and especially around cannabis, that becomes the way of of introducing the or I guess amplifying their own healthy skepticism and getting them to be aware that the stuff that they're taking is impacting their brain. And they kind of know that, but the more you think about it, the more it starts to be a little bit ego dystonic. And so anyway, that's a short snippet.
Oh, one more. We'll take one more.
Thanks. Great talk. It was really helpful. I just had a question. You said something about your personal opinion and where you might bring that in, maybe in the same discussion with the teenagers. And if that, I find that they are often asking me what I think about it, and I just wondered how you use that.
I think that it really depends. It depends. If they want my personal opinion, I'm wondering what they want. Are they looking to kind of entrap me, or are they looking for my endorsement? Are they looking for my to relate to me? And so I'll often start out with the frame of like my evidence-based orientation, so I can figure out what do they want as they're asking me in that, and because I find sometimes that I've learned through my mistakes all the times I shortcut it to kind of get into it, then it sometimes only becomes apparent to me later why it is that they were asking that in the first place. So what I try to be careful about doing is not doing the therapeutic neutrality thing, because it is an expression of caring about what I think or my attitude or and I value that, and so it's different for every person. How to kind of strike that balance. So thank you for your attention. 2.5 hours on cannabis, and in the same seat is a feat in and of itself. Have a great afternoon. And,
Thank you for Dr. Danovitch.
Appreciate it.